Coming to the jackknife position, is a modification of prone position, mostly used for anal surgery or pilonidal sinus excision. Place patient prone with head and feet at the lower level, and the head in the lower level, and the leg also in the lower level. So here again there will be very much decrease in the venous return to the heart, so there will be decrease in the cardiac output. And whatever complications of prone position we have read, in this patient also we will found that type of complications. But here you can see, here the padding is given, here padding is given, here padding is given. Here the arm is not adducted more than 90 degree. See, adequate amount of neck flexion is maintained, and pillow is given in the head. So we have padded everything. See, there will be padding inside the abdomen also. Knee chest position, hardly we do nowadays. We do mostly for the sigmoidoscopy or lumbar laminectomy or for rectal surgeries, but we achieve in the lithotomy position. So exaggerated jackknife position it is used for sigmoidoscopies, lumbar laminectomy. Severe hypotension is due to the pooling of blood in the legs. You can see here is the leg and here is the heart. So there is severe pooling of blood in the leg, and there will be hardly any venous return to the heart. So there will be severe hypotension, or the cardiac output is severely decreased. Here also we padded the knee, anterior talus and toes, rib cage, cheek and ear. So padded, definitely it is the proper position, but it is so many complications. Coming to the Trendelenburg position, it is mostly done for gynecological surgeries. We mostly come towards Trendelenburg position. So here what happens, the position of the patient is like this. So the head goes down and the leg will be elevated. So there will be proper venous return, the cardiac output is maintained. No issue with the cardiac output. But second thing is that all the abdominal content will force towards the diaphragm, and the diaphragm will push the lungs so that there will be decrease in FRC. Second thing is that like already some patients are in the cardiac compromised state. When we do such amount of Trendelenburg position, there will be sudden increase in the venous return, and the heart failure will be there. Third thing is that so much of Trendelenburg position will also cause some amount of airway edema, some amount of orbital edema also, but lesser than the prone position. Third thing, we have to ventilate the patient with a higher peak pressure or a higher airway pressure. And whenever the patient is in spontaneous, it is very difficult in the part of the patient because there will be very increase in the work of breathing. So we avoid this type of position in case of obesity patient or in case of pregnancy patient, unless it is very much required. Here you can see how nicely the patient is put in Trendelenburg position. See, the legs are tied here. Here we have given two shoulder support. This shoulder support should be very much soft. It should not create so much of pressure in the shoulder. The neck in the midline, the neck neither has hyperextended or hyperflexed. It is maintained in between the two shoulder. The forelimb or the two limbs are tied just besides the body. So and it was tied with the operating table. So it is the good position, and here the position has been given very properly. In this way you have to answer in exam also. So what are the problem? Diaphragmatic movement can be limited. So because all the abdominal contents are pushed towards the diaphragm, so there will be a limited movement in the diaphragm. FRC somehow it is decreased, and there will be ventilation perfusion mismatch and increase in the work of breathing. Ventilation perfusion mismatch definitely. ICP, yes, I forgot ICP, but here also ICP is very much increased because the neck, the whatever blood inside the brain or whatever the venous drainage to the brain, the blood from the venous system cannot empty the brain. So there will be definitely increase in ICP. Preload and stroke volume increases. There will be maintenance of the cardiac output. Reverse Trendelenburg position. So here is elevated, head elevated laparoscopic position. So mostly during laparoscopic appendix we do this type of position. So here decrease in ICP. Venous drainage from the brain is good, but venous pooling is very much rare. Chances of venous air embolism is somehow possible, but it is less as compared to the bridge chair position or sitting position. Some amount of hypotension we face because of the pooling of the blood to the lower limbs and decrease in cardiac output. Here we always apply the shoulder braces to avoid prevention or to prevent the brachial plexus injury. So here the head or the arm should be rest besides the body.